the fact that there is an acceptability range in pediatric fractures means that in every case, it is not necessary to achieve an accurate anatomical reduction. Now, why is that so? That is because in some fractures within an acceptable range, malunions may not have any cosmetic or functional implications. And a prime example of this is fracture of the clavicle. Certain malunions may be well compensated by mobility at the adjacent joint, for example, proximal humerus fractures. And of course, in children's fractures, we have the tremendous potential for remodeling, which Premal is going to talk about in the next upcoming talk. However, it is important to remember that having an acceptable range does not absolve the surgeon of his or her responsibility to make every possible attempt within reasonable limits to achieve as normal alignment as possible. So, even though there is an acceptable range, we should strive to achieve as good reduction as possible. So with this background, let's go to the acceptable criteria of some of the common pediatric fractures. I'm going to put up a lot of charts and quote a few figures. Please don't try to learn these by heart. We can forward these charts, Venkat can forward these through a PDF later on. So starting with clavicle fracture, this publication from Canada in 2007 was kind of a watershed moment in the treatment of adult clavicle fractures, and what they proposed is that fractures which are jet-shaped, more than 100% displacement and more than 2 centimeter shortening, they have poor functional results if treated conservatively. Hence, there was an increasing trend towards surgical treatment of these fractures. Unfortunately, though there was not any evidence, the same acceptability criteria were adopted for adolescent pediatric fractures, with the result that in the subsequent years, we saw a significant increasing trend towards surgical management of adolescent clavicle fractures. However, thankfully now, we have sufficient data to prove that in adolescent pediatric fractures, clavicle fractures, surgery demonstrates no benefits in terms of shoulder function and return to sports. Therefore, in clavicle fractures, the alignment of the fracture does not determine the method of treatment. The only indication for surgical treatment is open fractures, impending skin perforation, and neurovascular injuries. Moving on to proximal humerus fractures. Now, these fractures have an excellent prognosis because they have a great remodeling potential due to their proximity to the growing proximal humerus physis, and plus the multidirectional mobility of the shoulder compensates for any malunion if present. There is no consensus regarding the exact degrees of acceptable alignment. As can be seen from this chart, various authors have proposed different acceptability degrees. However, I like to refer to this chart from Rockwood-Wilkins, which, so the acceptability criteria are age-related. In children up to 10 years of age, up to 100% of displacement is acceptable and 70 degrees of angulation is acceptable. More than 10 degrees, you would tend to accept around 40 degrees of angulation and 50% of displacement. However, in the distal, the criteria may be more stringent for overhead athletes. Moving on to humerus shaft fractures, again they have a good remodeling potential. Shoulder compensates for malunion if any, and cosmetic deformity is usually masked by muscles of the arm. The acceptability criteria described are varus up to 20 to 30 degrees, apex anterior angulation of 20 degrees, rotation of 15 degrees, and shortening of 2 centimeter. However, as you move towards the distal third of the humerus, you should not accept varus because that usually produces unacceptable cosmetic deformity. Moving on to supracondylar humerus fractures, and in the coronal plane, the deformity is assessed by calculating the Bauman's angle. The normal range of Bauman's angle is 9 to 26 degrees. If this angle is less than 9 degrees, it indicates varus and should not be accepted. In the sagittal plane, the acceptability is determined by drawing the anterior humeral line. It should pass at least through some part of the ossified capitulum. If it does not, then it is not acceptable. Rotation, which is identified by noticing difference in the width of the fracture surface of the proximal and distal fragment, indicates that this fracture is probably unstable and therefore it can drift into varus. There is no real data regarding how much degree of rotation is acceptable in a supracondylar humerus fracture, but because these are unstable fractures, you should tend not to accept rotation and correct it as much as possible. Moving on to proximal forearm, so radius neck fractures. Here again, the acceptability is determined by the age. In children up to 10 years of age, about 45 degrees of angulation can be accepted. More than 10 years, up to 30 degrees of angulation can be accepted. The importance of angulation in radius neck fractures is that angulation beyond a certain degrees, it will result in cam impingement at the proximal radioulnar joint and thereby impede the pronosupination movements. Coming to a very important fracture, that is the radius ulnar shaft fracture. And here the acceptability is determined by the age and the level of the fracture. Here we usually refer to the criteria as described by Charles Price. So less than 8 years, about 15 degrees angulation, 45 degrees rotation, and 100% displacement can be accepted. More than 8 years, you can accept up to about 10 degrees of angulation, 30 of rotation, and 100 degrees of displacement. Additionally, you should try to restore the radial bow as much as possible. A few more points have to be taken into consideration in radius ulnar shaft fractures. So as you go towards the proximal forearm, your limits of acceptability become more stringent because any angulation in the proximal forearm would result in more profound loss of pronosupination. So in the proximal forearm, your acceptability criteria should be more stringent. Also, every effort should be made to correct the dorsal ulnar bow because malunion with a dorsal ulnar bow can result in unacceptable cosmetic deformity. Also, the interosseous space should be preserved because that determines your range of pronosupination. Coming to distal radius fractures, and these fractures again are close to the distal radius growth plate and therefore have an excellent remodeling potential. In the sagittal plane, we know from this well-cited paper from Hawaii that in children less than 10 years of age, 100% of overriding can effectively remodel. And therefore, in these fractures, you need to only correct the angulation and can leave the overriding as it is. Also, we now have data regarding the coronal plane remodeling, and what it has been shown is that if there is at least 1 year of growth remaining, then coronal plane angulation remodels at the rate of 2 degrees per year. So within 1 year, you can correct about 24 degrees of coronal angulation. Regarding the exact degrees of acceptability, again, different authors have proposed different degrees. I tend to follow these guidelines which have been given in a recent J. Posna article. So about 25 degrees of dorsovolar angulation, 15 degrees of radioulnar angulation can be accepted in distal radius fractures. Finally, coming to lower limb, and in femur fractures, again, these fractures have good remodeling potential and young children remodel better. However, that does not mean that you can abuse the remodeling potential in young children. For example, this was a child 1 year old which malunited in almost 90 degrees of angulation, and even at the end of 3 years, he had failed to completely remodel. So you have to be aware of the acceptability criteria even in very young children and not leave everything to remodeling. If you look at this chart, again, the acceptability criteria are determined by the age. In children who are more than 11 years of age, about 5 degrees of varus valgus and 10 degrees of sagittal angulation is acceptable. Finally, coming to tibia fractures, and this is the chart, the acceptability chart. Again, as you can see, the older the age, the more stringent the acceptability criteria. In general, varus remodels better and anterior angulation remodels better. So to conclude, children's fractures have a wide acceptability range. Knowledge of this range can help us to avoid unnecessary surgeries. However, as a surgeon, every possible effort has to be made to achieve as good alignment as possible. Thank you.